Elliot, what do you think of this case?
Okay, so we're looking at the distal leg.
Yeah, so this is a very old low field study.
Uh-huh.
Maybe this is a vessel, maybe it's something. If you go to the axials. No, let's forget this case. This is not.
Yeah.
Let's do this one.
Okay, 49-year-old runner, pain for 2 weeks, rule out stress fracture. Um,
Yeah, this is an old study.
okay, is it the we see some maybe cortical thickening on the on the right or yeah, left side of the image. Yeah, edema in the bone. Yeah, same thing. Some linear edema in the bone.
So low signal on the T1, increased signal intensity on the T2. So we have some edema within the bone.
You're too far away from the mic, John.
And here we have a PD fat set. So again, we're seeing edema in the medullary bone as well as in the adjacent to the periosteum anteriorly. And then you want to look carefully for any abnormal signal within the cortex. Here we're just seeing medullary and periosteal edema. And this was an LVU stress fracture. Whereas John was just saying these are also called fatigue fractures.
All right, 7-year-old female. We're looking at a femur. Looks it's like some bowing to it, maybe. And
What do you mean, maybe?
maybe some thickening of the medial side of the cortical thickening.
Periosteal
Yeah.
thickening here, kind of reading.
There's a doubt in your mind about the bending?
Didn't know where we were at for a second.
Okay.
You know, I'm not,
So if you notice here, there's this little bit of edema. Right?
yeah,
Adjacent to the cortex. On
Yeah.
that side. And then.
When you speak, John, I cannot hear you.
Right. Okay. And then here we can see a little bit of edema right adjacent to the inner cortex on the axial images.
yeah.
And here's the bone scan.
Because we have focal radiotracer uptake mid femoral diaphysis.
Yeah. And notice you get bowing really of both femurs, abnormal bowing. And this is actually typical of biphosphonate-related cortical stress fractures. And this.
The bone gets more elastic.
Yeah.
All right. So looking at the tibia on the plane radiographs, it looks like there's a small or thin.
Wait. Bone is elastic. But only to a certain degree before it breaks.
Okay.
Okay. All right. So looking at the plane radiographs, it looks like there's some calcified structure on the lateral side of the tibia there, and it's on the MR. It looks hypointense on both sequences there. So some sort of calcified structure, maybe.
Yeah, so this is called interosseous ligament ossification, and it's really ossification of the periosteum, and
Okay.
it's considered normal. Okay.
Wouldn't that be endosteal, John?
Endosteal, I think, would be on the inside, right?
No, yeah, no,
This
I'm
is
sorry.
outside.
That's
Yeah.
periosteal.
Yeah.
Okay, we have a 1-year-old female. born premature, tachypnea, PDA ligation, fell down from the bed, now blood-tinged stool. No intussusception. Radiographs. Yeah, the left femur. Maybe there was a, you know,
2006. Here's 2007 through fall.
after the fall, there's around the left femur, there's just, I think, this lifting of the periosteum with a hematoma around it, given the history.
So what is it?
Like periosteal lifting with the hematoma.
So it's a classic chronic periosteal hematoma, and you can often see that it can have a laminated appearance due to intermittent bleeding and not bleeding, and that calcifies.
Excuse me a second. This is when you see something like that in an infant, you have to start thinking about abuse, which is usually by the parents or maybe babysitters, etc. Usually it's the parent. And I happen to have a case many years ago that broke a femur, and mother claimed that the infant fell out of the bed. The infant was 6 months old, and there's no way that the baby could have fallen out of the hospital bed. And then we got some more x-rays. The pediatrician didn't have a clue which is kind of interesting. And I called in a social worker, we called in the police, and wound up in court, for which I got $35 for testifying. And then about 5 or 10 years later, I find out I made up with a lawyer that I was playing golf with, and it went to the legislation, and they came up with a punishment for abuse and not reporting abuse of children. And interesting, my name wasn't in there, but he said my case started it.
All right. Good.
All right, so say skeletal immature patient. I see some abnormal signal maybe in the growth plate in the proximal tibia. I was thinking lower proximal tibia maybe. Is that something going on there?
This looks like a little bit like something we saw last lecture, right?
Yeah, is it
Folk?
a phobe? Yeah, okay.
Yeah, I think this is normal.
Okay.
What do you think about this?
Oh, is that a subperiosteal hemorrhage?
Right. So that's subperiosteal hemorrhage. And then here on the axial T2 weighted difference, you can see it's low in signal intensity. It's a little bit older person, and that's a subperiosteal hematoma. Just remember, in kids and young teenagers, bone trauma can often present as subperiosteal hemorrhage, and it's important to pick that up.
All right, so we have a pediatric elbow here. How old is he?
It's a very good question, and I don't know.
Yeah. I don't see an obvious fracture, but let's see.
So the thing here is that we can see see some of the ossification of the end plates, and then here on the trochlea we can see that it kind of funny ossification there. So they were concerned about injury, so they got an MR scan. Here's what the MR scan shows.
Let's see. Capitone looks okay. That's ossification.
So here's that area of early ossification.
Yep.
We have a little funny area here, which on the stir image we can see has edema
Okay.
within the articular cartilage right there. And this turned out to be an epiphyseal injury, but this is normal ossification, early in ossification. But there was an injury to the articular cartilage, but in these young kids like this, these heal very well. So this was treated conservatively, and to my knowledge, the patient did well. But the MR did document that there was an injury to the cartilage.
Sure.
All right, well, you're all aware of the Salter-Harris classification. One is an injury just of the growth plates itself. Two, there's a fracture that extends into the metaphysis. Three, it extends to the epiphysis. Four, both sides, and the five is a overall crush injury to the growth plate, with each of them getting progressively worse prognoses. Fortunately, type 2 is the most common one, and usually can be treated effectively.
Campbell's have six.
What's the sixth one, John?
There's a fracture of the tibia that has a ring on the periosteal ring on at the physis, and there's a twisting injury that can produce a fracture, and it's called number 6 because one of the problems with it is you get premature closure in an area of the torque pressure, and so the periosteum, I mean, there's premature healing in that area, and you get a bone bar, which can be a problem in the future, which you have to remove, obviously, and replace it with fat. So the new Campbell's has 6
Okay. So
classifications, and then they still call us Salter-Harris, although it was another doctor that put that 6th one in there.
and how does that sixth one differ from a 5?
It's a torque, and only one area is injured.
Okay.
And it's this one is a crush injury.
Okay. Thank you.
And the other one is not a crush injury, so it's a torque injury.
Okay. Thank you.
But it's definitely in the literature, John. It's
Good.
Okay, so here we have a coronal T1. I see hypointense signal in the medial tibial plateau. Oh, well. Yeah, distal to the physis in the tibia. Looks like there's edema. Is there widening of the physis? So
certainly edema within the metaphysis, maybe some edema in the epiphysis and the physis. So coming here, but this determined it was a Salter line.
okay.
All right. So looking at the proximal tibia, I don't know, am I seeing some widening of the growth plate anteriorly? Like a Salter 1 still? Yeah.
All right. So we have a 13-year-old medial pain after trauma 9 weeks ago. Looks like there's a little bit of a DRUJ effusion. Looking at the ulna, there's an increased signal in that physis.
Yeah.
Again, the
So
sulfur.
this is another Salter one.
14-year-old pain after football injury. We see a lot of soft tissue edema around the knee, in the tibial plateau, okay, or in the fibular head. Maybe there's a defect. Okay, so we have widening of the physis, the proximal tibia. It looks like there's a structure that's gone into the growth plate. Maybe that's the
Periosteal is torn over here.
yeah.
Looks like the growth plate is thickened. That's just
Yeah.
so what's going on?
Could that be periosteum? That's maybe a periosteum that's flipped into the physis.
Right. So this is a Salter Harris tube.
Yes.
Metaphysis. We can see widening of the growth plate itself, and then this is periosteum that's flipped into the growth plate. And I think we might have talked a little bit about this earlier in the year. This is a little bit controversial. Most of the people I know would not go in and try to pull this out because they're afraid that they'll be producing more injury to the growth plate by doing that. And I've seen a couple of cases where this has been the case. They left it alone, and the follow-up that I got from the orthopedic surgeon was that the patients did fine. But on the other hand, a couple of years, 10 years ago, when I was giving this lecture, and a couple of people overseas watched the lectures and got feedback to me saying that that's wrong, that this absolutely has to be removed and taken out. Otherwise, you won't get proper growth. So I think it still is a little bit controversial, though the majority of people I know would not go in and surgically remove this if everything else is fine. John, I know you're not discussed this many times.
What has happened in this fracture is that the physis opened up and sucked in the periosteum. And if you look at it, there's a little bit of a difference in measurement of where the periosteum is versus where the fracture is in a tibia, in a proximal metaphysis area. I mean distal metaphysis. And I see no reason to operate on the child, open everything up and then pull on it. And you have to open up the physis again. So that's a double injury to the physis. And you may be injuring more tissue by doing that. I would leave it alone because children at this age heal pretty damn well.
Okay.
All right. Sports injury 5 weeks ago. So it looks like there's some asymmetrical widening of the physis at the distal femur. I don't know if is that a real fracture line extending to the metaphysis right there? Yeah.
It is.
So it's all
Right at the edge of the widening, which is
Yeah.
classically where the fracture line is positioned. Yeah, if we go on the sagittal images, we can see it's 5 weeks, so this thing is pretty much healed.
Yeah.
That part of it. And then here on the axial images, you can see the fracture line coming across here.
Yeah. Salter too. Okay.
So this is a teenager with 2 weeks of pain. Looking at that distal femur, it looks like there's a fracture through the epiphysis extending into the physis. So Salter Harris 3.
Okay. Yeah, maybe it's getting a little bit here, but, and then we can see a second impaction injury over here. But this was considered a 3.
Okay, radiographs of the ankle. I think we're looking at the tibial plafond in the middle. There's a lucency there. Yeah. Maybe a little, yes, and some widening of the physis. So, yeah, fracture and the Salter-Harris 3. There's a fracture of the posterior malleolus. So yeah, it's going through the epiphysis and through the metastasis. So Salter-Harris 4.
The accident, which is it's also displaced.
Yeah.
So this is a pretty severe fracture. Extends into the there's widening and extends into the joint space. We can see here. So there's it's a very significant high risk type 4. And this just shows a fracture going here.
All right, 29-month female, bilateral tibia vera. Oh, man. This is a board's case, I feel like.
What?
So there is some irregularity of the medial aspect of the metaphysis, bilaterally causing a varus deformity.
There's the MR.
Yeah, so we see that irregularity of the medial aspect. Oh man, I can't remember the name of this though. Yeah, yeah, I'm bad with eponyms. Blount's
Okay, so
disease,
this is
yeah.
Blount's disease. Now, early on from 1 to 3, this can be very normal. When you get into adolescence, it's not so normal anymore, especially when it gets later onset. John, do you want to talk about this?
I've treated my share of these, but they, if it's a true Blount's disease, most of these are physiological bowing. But if it's true Blount's and you made a diagnosis, um, you're in for a ride for the future. You have to do multiple osteotomies, and there are all kinds of different operations that are now proposed for taking care of Blount's that I cannot get into. It's too many of them. But I used to do osteotomies proximally and try to keep up with growth of the individual. You take out the wedge on one side and you put the wedge in the other side, and etc. It's a pretty tricky process. You don't want your child born with Blount's disease.
Thanks, John. There are classifications, but I really don't think we need to go into that. And yeah, so it's mainly the growth disturbance, but if the growth disturbance is associated with a lot of other findings. And you can see edema, the late ossification, widening, and so forth. Just kind of some examples of what Blount's disease can look like. Here we can see the abnormal growth plate and the deformities here in later Blount's disease.
All right. We have a 7-year-old with epiphyseal fracture follow-up scanogram, right left growth or leg length discrepancy.
Good.
Let's see. Some flaring of the distal metaphysis of the femur, yeah.
Yeah.
Some bridging across the physis there, looks like.
Okay.
Yeah. Yes, it looks the same on the MR. Some bridging.
Yeah, you can see that bar very nicely on the MR scan here and on the CT.
Yeah.
Multiple bars there. So those are rigid cortical growth plates. So John, do you want to talk a little bit about bone bridges and how you handle those?
When you have bridging, especially in this area, this is a difficult area to get into, but you would have to go through the distal tibia above the physis and then re remove the bridging and just introduce fat from the buttocks. I did this as 2 areas of bridging, I think, and you put in the fat, and the fat prevents regrowth of bone, but the physis comes back in that area, and these work out pretty well. I never had a failure on one of these, and I thought I done probably close to 100 or so.
Thanks, John.
You're welcome.
Okay, 9-year-old gymnast fell from bars.
So you can get injuries then.
Oh,
Sorry.
yeah. Uh, okay. So the red arrow,
Arrow sign positive.
area of deficient periosteum. Yeah, so it looks like the periosteum's entrapped again in the.
The same thing can happen in the upper extremity.
Mhm.
So, the same discussion. You can see that periosteum was torn down here. The growth plate opened up and it flipped into the growth plate. So this is not a rare occurrence. And this is from down under. One sure way to cause the physis to arrest is to operate on it 3 weeks after separation. So the orthopedic surgeons in Australia would agree with Dr. Yorgutis.
Right. 52-year-old, 2-week history and knee pain. So,
So the question here is, what's the actual true history?
they their gun went off in their holster. Yeah.
Yeah, he was doing his quick draw, and his finger was faster than his draw. Dagger than him.
Yeah.
If you want to practice, take the bullets out. If you don't, you're kind of lacking a few cells upstairs.
All right, so we have a 56-year-old male with pain after a fall. There's a lot of susceptibility artifact. It looks like there's a fracture through the proximal or distal femoral diaphysis. Yeah.
Yeah. So this is acute fracture in someone who has an intermedullary rod from a previous fracture higher up. Right. Okay. So we can look at some chronic injuries now. We've already seen this. This is grade 4 chondromalacia. In this case, this is with the tourniquet on. They did a microfracture technique, kind of putting little holes all through this. Take off the tourniquet and it bleeds in that area. And we already talked about this in the articular cartilage section. You can actually get growth, kind of a fibrous cartilage that can grow in the area of the fibrin clot or the clot in this area. But as we talked about in the articular cartilage section, microfracture is now really not really recommended, especially in athletes, because there's much better outcomes if you do osteochondral grafting or chondrocyte transplantation, more modern techniques. And then here's just an injury to the bone. You can see the cartilage is abnormal signal, but it looks like it's grossly intact. patient continued to weight bear, and we can see that the cartilage has a full thickness defect, and now we've got underlying marrow edema. So this is progressive degenerative disease in this particular patient. Okay.
Okay, teen soccer.
Kid who had intermittent knee pain bilaterally for 3 years during soccer season.
There's some cortical irregularity along the medial metaphysis of yeah, kind of right there, and the femurs.
Yeah.
I'm not sure if that's a finding.
From the thing here.
Mm-hmm.
You do CT scans.
So, yeah, this curvilinear looks like an ossification along the lateral aspect of the distal femur. It's in the location of the, is it the iliotibial band or in the femoral the condyles of okay. Here.
So this was in 1990. So we recommended an MR scan, that newfangled device that nobody was using for the knees at that particular time. And this is what the T1 axial images look like. Now, this was sent around to a bunch of different orthopedic surgeons to try to decide what this was. The consensus was that this is just normal irregularity of the ossification stage during growth on the CT scan. And but here's what the MR scan shows. Here is the axial, and here's the coronal and the sagittal.
Yeah, there's abnormal signal in this lateral femoral condyle. Looks like a cortical irregularity anteriorly. Maybe a subchondral fracture or an osteochondral lesion.
Okay. So what this were bilateral subchondral fractures, osteochondral injuries, with the subchondral bone displaced bilaterally. So what you see here, that's the displaced subchondral bone on both sides.
Very symmetrical.
And very symmetrical. And here's the, we can see the bony changes. And on the MR scan, this is clearly abnormal. Even in 1990, we'd had enough experience with the MR scan to know that's not physiologic. So these are both due to repetitive trauma with osteochondral injuries and displaced fragments.
All right, 12-year-old knee pain. So looking at the medial femoral condyle, there is a subchondral fracture there, but there is overlying cartilage that looks intact.
Okay. I think we saw this case in the cartilage section. So this day and age, people might call this a bone out lesion. Again, that's due to impaction. The cartilage is deformable without breaking. The subchondral bone and the trabecular bone here is more rigid, and if it impacts it enough, instead of just giving way, you go past the deformity stage into the fracture stage. So we have a really subchondral trabecular fractures. You can see the subchondral bone is probably depressed a little bit here as well, though the overlying articular cartilage is intact. If you remember, in this case, the kid came back 5 years later, and this is what it looked like 5 years later. So in this day and age, this was called osteochondritis dissecans. There's a big debate about what this is due to. All of the cases that we've been able to follow over time, and we've seen a few of them now, look just like this. They start out with a subchondral fracture, and what happens is that the kid continues to play and doesn't allow that to heal. the fracture becomes larger and larger. Then you get an unstable fragment here, and eventually this will lead to a full osteochondral defect in that particular area. It was debated, it was thought back in the 1980s and before that this is due to basically bone infarcts, to vascular damage. This is all traumatic. It's really not due to, I mean, I guess you could occasionally have somebody who had some disease like sickle cell or lupus or something where they'd have bone infarcts here. But overwhelmingly, this is all due to repetitive trauma and not allowing it to heal.
Yeah.
And another example here where we have a subchondral bone fragment, osteochondral injury. Here, the overlying articular cartilage is not intact in this case, and this will eventually go on to a displaced fragment, and you get a big defect. And this is just further examples of more severe cases of these subchondral fractures.
All right, so we have x-rays of the knee looking at the lateral femoral condyle. There's some irregularity
Yeah.
of the, yeah.
Yeah, you got another osteochondral injury. And here we can see the kind of subchondral fracture injury with, in this case, we have a pretty well-defined interface between the central fragment and the underlying bone, which we can see in this case. It's another osteochondral injury. Here again, the overlying articular cartilage is probably intact, and so this may be belaudable by arthroscopy, but difficult to see directly. And this is again a subchondral fracture, and these need to be stabilized. The patient need to be off active weight bearing to allow these to heal, or they'll go on to an irreversible lesion.
Yeah, you can nail that, but you need to go from the side.
Okay.
Okay, so there's irregularity and depression of that the lateral tibial plateau. Is this acute or chronic? And with edema. Well, I would say chronic. Yeah.
Yeah, and then when it's acute, what you will typically see on a PD FET side, you may see edema like this. It'd probably be a little bit more prominent, especially with this amount of depression of the subchondral bone.
Depression fracture.
Yeah. But in the acute stage, you'd see much more edema with this kind of compression. And then on the T1 weighted images, when it's chronic, you get very sharp margins like we're seeing here. And you can get eburnation of that margin, which we're just beginning to see here. In the acute stage, on T1 weighted images, the margins are very indistinct. So this is predominantly a chronic lesion.
You look at a muscle distally, it looks like it's fatty atrophy.
Yeah.
To me, anyway.
Yep.
Am I right or wrong, John?
You're right. Good.
And so this patient was not walking pretty much. I don't see how he could walk on that unless he was a drug user and whatever.
Okay.
All right. So this is the lateral compartment. I think the menisci are intact and the
Okay.
cartilage looks okay.
Looks pretty good. So
Yeah.
this is 2404.
Okay.
So now the patient, this is now 4 months later, and it looks like this.
All right. So we have a subchondral fracture, weight-bearing lateral femoral condyle, and cartilage,
full thickness cartilage too.
defects.
Yeah. Yeah. So So this is an osteochondral injury. Here's a displaced fragment. So just pointing this out that this is what it was perfectly normal 3 months before. And now we can see that it really looks like it's chronic. So these injuries can look chronic fairly rapidly after they've been around. And this is unstable, as you can see there. And here's a displaced fragment from that area.
All right. So looking at the lateral femoral condyle, there's a lot of edema, maybe a subchondral fracture there as well.
Yep.
Yep.
And this patient landed on their knees, fell on their knees, and had a direct impaction injury. Okay, so this is a patient who came in with a history of spontaneous osteonecrosis.
Okay, so in the medial tibial plateau, there's just mixed, there's irregular signal. The subchondral bone looks intact.
Probably a little depressed.
Okay.
There seems to be
Yes.
some depression in my
Okay. So, yeah, a fracture of the metaphysis with some depression.
If you notice on the margin there in the tibia, there's a buckling present right there, and that's an obvious compression. And
So this was another debate in the years past, the term spontaneous osteonecrosis, and that was used for many years after we really pretty much proved that these are all traumatic injuries. So this is really a subacute traumatic impacted fracture. Another case
probably a fat woman.
What, John?
Probably a fat woman.
Okay. So this is someone else who came in with a diagnosis of spontaneous osteonecrosis.
Okay, well, we have very extensive edema in the articulating surfaces of the medial compartment, and then there's a low signal line subchondral medial plateau. It's like a stress fracture.
Yeah, well, these are, again, subchondral fractures. In this case, some people would call this an insufficiency subchondral fracture, probably because the patient's probably osteoporotic and overweight. Yeah.
Okay.
All right. So we have images of the knee in the axial plane. Looks like there's a fracture of the patella that extends into the articular surface. Yeah, and then there's a second arrow on the left-sided image that looks like it's breaching the articular cartilage there as well. And then there's edema in the femoral condyle.
I don't know why they're all the arrows. So what do you think happened?
I mean, given the edema in that lateral femoral condyle, I think it was probably a dislocation of it.
Yeah. So this fracture dislocation of the patella. Right?
Okay, looking at the medial femoral metaphysis, there's T1 dark signal. There's edema in the physis, and let's see. Yeah, the sagittal looks like is that a fracture? Fracture line coming down?
Salt or what?
Salter 2.
Agreed.
Uh,
No.
this usually isn't classified as a Salter injury. These are pretty common. They may or may not be symptomatic. That really occurs posteriorly here in the metaphysis, and these have various names. The most common one is a cortical desmoid. And what is this due to?
Traction from the megagastro.
Right. So this is a traction reaction within the subcortical bone here due to traction from the gastrocnemius. The reason this is important is if these are biopsied, and there's this, I know of some individual cases of some pretty famous people who have had these biopsied at major institutions. They were called osteosarcoma, and at least one was amputated. And these are chronic traction injuries. This is a typical location. This is a typical appearance. And it's important to recognize that as this is a leave me alone, do not biopsy lesion. And with rest, these will heal.
What about the physis on the sagittal view? It doesn't
Here.
look normal.
Yeah, well, there's a little bit, this is all kind of a stress reaction all through here. And in this particular case, it's involving a little bit of the growth plate. But again, these do very well with conservative treatment as long as they're recognized as to what they are.
Well, it's certainly not a typical fracture line. It's a double line.
You're saying like once they biopsy it, like a periosteal sarcoma is going to look similar on pathology?
Yeah. When you get healing bone like this, the cells can look very bizarre. And it can be very difficult to differentiate them as to whether they're malignant or not. Now, once it's recognized in a situation like this, one of the things you can do is wait. It's unlikely that if it's an osteosarcoma, especially like this, where there's no mass, no periosteal reaction, this does not look like a malignant lesion. It's not going to metastasize and kill the patient if you wait 6 weeks. Within 6 weeks, the healing will actually occur, go through the healing phase, and at that point, if you biopsy, it will not be such bizarre
I see.
cells. John?
You don't see any lysis on that particular image. So that would, as you said, leave alone lesion.
Yeah.
But I would still follow it.
Mm-hmm.
Wouldn't you?
Generally, I don't follow up on these. Once it's recognized what it is, then they usually, in my experience, are treated clinically. And as long as there's no complications, we usually don't image it again.
Is there any advantage to using diffusion imaging or enhancement?
Why did the patient have the MRI? Because of pain?
Yes, because of knee pain.
Okay.
Yeah. The question is whether diffusion-weighted imaging or contrast would be helpful in this, and I don't think so. This is just such a common characteristic location and finding that it's a very definitive diagnosis. And I think the only thing that would happen with other imaging is it might complicate and confuse the issue. We're gonna do a foot and ankle later. So why don't we stop here and we'll move on to another topic tomorrow.
Okay.
And we won't, okay,